Thank you very much. Thank you for this introduction. I have experience with these great introductions. After this, if it's too great, everything is downhill after. So, but let's try. Thank you so much. So we've been working on something we call precision medicine, and I make no apologies for this. I think it doesn't really matter. We are going to have a debate later with the second speaker. I think that if there are more conferences like the one today, this will be just medicine, medicine as we practice it, and no word before will be necessary. But stay with me, because we've been in Scotland and UK working on making precision medicine accepted across our communities for 9 years, about a decade. It will be 10 years from the first innovation center next year. So what I'm going to say today would be mostly based on my work as a Regius Professor of Medicine at the University of Glasgow. A little bit of COVID at the end. I couldn't resist, Bernie. But clearly now, since 1st of July, I've been a Chief Scientist for Health in Scottish Government, and that allows me to see a broader perspective and perhaps push a little harder for precision or personalized medicine. So that's what I plan to discuss. I already said it. The name doesn't really matter. We need to be ready for clinical and healthcare translation and adoption. And as a Chief Scientist Health, I have been working with my colleagues across Scottish Government and the NHS on the adoption, on this last stage of implementing new things into the NHS. And as you know, that's not easy, but we have some really good new ideas. I'll talk a little. I know there are health economists in the audience. I'm not, but I worked with Scottish health economists who are, as you probably know, very good and world-leading. And we have some really great ideas that implementing precision medicine actually makes everything cheaper, not more expensive. Early on, there was this criticism, if you'll be doing all these tests, it will cost a bomb. It's not true. Actually, you're saving. We will talk a little about Living Laboratory for Precision Medicine. That's our huge grant that shows that collaboration that was mentioned before. You can't innovate without industry. We've learned this early on. I mentioned what Americans are doing because one has to. I'm not sure it's any better than what Europe is doing, frankly. And I'll mention COVID-19 because I think we shouldn't allow the legacy of diagnostics that Bernie mentioned go away. We need to keep the few good things that happened during this 2.5 or 3 years. So first of all, our academic center, which we built approximately 10 years, well, not yet 10, 9 years ago. And it was built, university and NHS together, according to this philosophy that triple helix collaboration is the only way to succeed. And it's not just precision medicine, it's everything we do, I believe. So the construct has always been that on research, development, innovation, university has this lead, but working hand in hand, very, very closely with our NHS and life sciences industry and the digital industry and AI and machine learning, everybody together. In a little more detail, these are various constituents that over the years allowed us to do this. This big new clinical academic campus was opened 9 years ago, and we collected all these things to make triple helix possible. I'm not going to go through everything, but of course data. So we have Safe Haven. This is that secure environment to exchange data with industry, the Innovation Hub, the Innovation Centre funded initially by Scottish Funding Council, now Scottish Enterprise. It's moving towards industry support more and more. So that working where people don't really know what is NHS, what is academia, what is industry. Everybody is together. The so-called white coat distance, you might have heard. Of course, we as clinicians no longer wear white coats, so this term is a little old-fashioned, but nevertheless, industry really likes to be close to clinicians. They can ask questions. I'll expand on this a little more, and that's what we created when building this new campus. There is another element. Somebody said before, I think the minister, about reaching everybody, about equity. That's hugely important. So our living laboratory, our hub of innovation, is placed in one of the biggest centres of deprivation, not only in Scotland, but in whole of the UK. And that's why we were able to win the Levelling Up huge grant from UKRI, the Strengths in Places Fund. You see in the red, this is the Scottish Index of Multiple Deprivation. It goes 2020. It hasn't changed, unfortunately. If anything, as you know, COVID made it worse. And we see here, the redder the area, the more deprived on multiple features that you see there. And our academic centre is in the very middle of the most red of the red. And we're working really, really hard to bring high-value jobs to the area, to bring economic growth. This is not just about medicine, as it's been said before. Now, this is my early definition of precision medicine or precision healthcare or personalized medicine. Please, let's not get stuck on titles. I think we always have affected population, or healthy population for that matter. We use our tools where genetics, genomics, molecular is only one of many tools. That's not everything. People occasionally think that when they sequence lots of genomes, and I've seen this internationally, it will be done. Well, that's not quite true. We also need old clinical stuff. That's where Americans sort of not always win, because they don't really examine patients anymore, just put them into machines. Sorry, please don't quote me on this. I spent my formative research year and a half at the University of Michigan in Ann Arbor. It was wonderful, and I loved being there. But I wouldn't touch a patient, although I could, because that's not what I like doing in that system. Now, medical imaging, which is bold here because many people forget about it, is, I think, hugely important tool, and we included this very early to our whole system approach, looking at therapeutic responses. And then you stratify, and that's why early on, for example, the Medical Research Council in the UK used stratified medicine for many years. This was really confusing for patients. We did some consultation with patients who didn't like stratified medicine. They felt that this was an equal way of delivering care. So this ends up with better, earlier, pre-symptomatic, frequently diagnostics, better prediction, prognosis. We do better for our patients, but also for our communities in population health. And also, do not forget that we start understanding molecular pathways much better than ever before, and therefore end up in new druggable targets. So it's not just about taking things we already have and treating. It's also new drugs, new treatments, new devices. That is all precision medicine in my book. As already been said, and I am not going to repeat this, that is a team sport. No single team in Ivory Tower could practice precision medicine. It has to be a big, multidisciplinary and multi-everything collaboration. As I said, no industry, no innovation, forget it. The question has been asked for the last few years, particularly loudly before COVID, and then we moved to other things, and it's coming back loud and clear. Are we ready for clinical adoption? And the answer is yes, particularly in cancer. I'm sure some of the talks later will talk about utilization in cancer. It is already in the clinic near you and in the clinic near me. But I would like the same in cardiovascular, metabolic medicine. It's coming, but a little slower than cancer for reasons that we all understand. But if you look at all the omics, this is not everything, but that's the cascade of omics with phenomics that has everything else, imaging, everything else we discussed. We really now have data analysis, ability to put it all together. We are ready for clinical adoption. We just need to push a little harder. We need an ecosystem, I believe, to publish precision medicine, and I am not alone in this. This is modified from paper, very good paper by Aronson and colleagues in Nature many years ago, 2015, ancient paper, and in some way. And yet it is still true. What I modified and added are two things. I added imaging that they forgot about because they geneticists, of course. And you know, I'm a physician, I like to see whole patient, so imaging, hugely important for me. And I also added other omics. Yes, genomics is absolutely great, and yes, in the UK, we have UK genomic program and group and 4 nations and everything, and now we have Scottish genomics. This is all great. But genomics on its own will not solve all the problems. And that's why I added these other things. I think proteomics, metabolomics do have, and biomarkers in general, do have a very big role. And don't forget pharmacogenomics, we're going to talk about in a minute. There is another issue here. It's not enough to have your own ecosystem in your own institution, city, or even country. It needs to communicate. And here I am jealous, very jealous. We're not in a horizon. We discussed this last night with colleagues. It's so difficult not to be part of big international collaborations. And collaborations far away in Australia, New Zealand, US, do not replace that European force. So remember about us, we want to join, please. Science has no borders, yeah? Now, on a serious note, my colleagues interested in AI, machine learning, particularly colleagues from Canon International Company, and I quote the leader here, Dr. Ken Sutherland, with whom I have worked for many, many years, developed something really interesting, which I think should be patented, developed further, etc., but isn't yet. So we heard the data. In Scotland, we've always been proud of our Chi number, the unique identifier that we've had for 20 plus years. We have the imaging data. We now digitalized almost all pathology. So we had a big, big initiative to digitalize pathology, no longer using the glass slides, but to have everything digitalized and on the computer. All these data sit in safe havens. We have 4 safe havens, 3 regional and 1 national, which sits in Public Health Scotland. We're making an enormous effort, as you do, to persuade, not to persuade, to hear that patients and communities actually do want their data to be used, not only for managing health service, but for research, development, and innovation. And our early analysis is that the patients really, really want the data to be used for the benefit of the public and their own benefit, but also their children and grandchildren. So as you see here, there is all the permissions sitting on one side, and then researchers, let's say small SME in AI and machine learning, sitting on the other side, but getting anonymized data safely so they can develop and perfect their system, being it closed loop for insulin delivery or whatever delivery of cancer drugs. So algorithm becomes their propriety, their IP, which they can then sell all over the world, because otherwise the companies cannot exist. So if we take, that's the clinician. And the clinician gets that cockpit. It's like on the aeroplane. The cockpit gives you all data. Here we see patient with pancreatic cancer, it happens, where a lot of imaging, 2 genomes have been scanned, the patient genome and the tumor genome, and all this can be taken quickly, we hope, quickly. Quickly is not the word with winter coming in our NHS, I'm afraid, but the theory is taken quickly to make decisions about therapeutics. Now, our innovation center I mentioned before is now nearly 9 years. It has this ability to integrate data, to partner with industry. And you see here that in addition to 2 cancers that were early projects there, ovarian cancer and pancreatic cancer, where we have world experts in all these areas, and this is across Scotland, not just in one place. And indeed, the ovarian cancer work already changed clinical practice. There is different stratification and different treatments. But in addition to this, you see MS, rheumatoid arthritis, also smaller piece of work on esophageal cancer, and liver, fatty liver and liver fibrosis. So broad spectrum, always working with industry, always working with partnership, and aim and ambition to adopt into clinical systems, not only in Scotland, hopefully around the world. Now, I said we have been really interested in economic opportunity of precision medicine, and before COVID, just before, we published with the base in London that audit. I don't know if you remember, there were several such audits going through variety of areas, energy, etc. We were one of the few in life sciences. And this was Precision Medicine Innovation in Scotland, produced by independent consultant, but working with us on this number of issues with focus on adoption. As far as economic look at it, and this was done by health economists, this is global market value at that time. So we're talking 18 to 19, the data were collected. And you see here that in 2016, global market value 43 billion. That was predicted by 2025 to be above 100. It's actually grown bigger because of COVID. I'll show you more recent data we received recently. We also calculated looking at main diseases. So that's beyond cancer. Yes, cancer, but also infectious diseases, etc. That Scotland, if we truly adopt into across our NHS, we could save 1.5 billion over 5 years. Of course, that hasn't happened. COVID happened instead. Now, in that audit, the consultants asked the companies, I think large number of industry partners, nearly 100, what they felt was the most important next step of developing precision medicine. And you see the results here. They published, and you see that 59% of industry partners said that we need to work on NHS adoption, mainstreaming precision medicine. I wasn't surprised. I think you're not surprised either, but that's a very, very strong push that the time is right, I think. There were other things you see here. Now, Scottish Enterprise, the Scottish Development Agency, performed repeat analysis. They call it gap analysis for precision medicine, which just been released. We had a meeting and discussion about it within last 10 days. And it happened that the same consultancy did this as did the base report prior to COVID. And this is interesting. So the global market is now about twice of what was predicted before COVID. I believe, we can discuss later, that that huge need for molecular diagnostics during COVID gave that increase. Some people think it might go down again post-COVID. We don't know. It needs to be observed. In Scotland, we have 100 precision medicine businesses, 100 who said they do precision medicine. As you probably know, there are many who do precision medicine but don't know that they do it, and we need to tell them, and I am on a barricade to do so. Now, our Innovation Centre, PMSIC stands for Precision Medicine Scotland Innovation Centre, only works with 25 of them. I can promise you that by next year they're going to work with at least 50. They also looked at this important database of industry, and it showed that we have a large workforce because of precision medicine, and this is increasing. And when they look internationally, I didn't make the slide of this, when they look internationally, Scotland is at the very top there. At least people know that that's what they do, which is not the case elsewhere. Now, what about our American colleagues and friends? Ginsburg, who's been very much involved in this area from Duke's University, published this paper with colleagues. This is a sort of workshop analysis. This is a joint view. And again, you see on your right, that adoption in very big, bold letters. So I think this is a repeated message, but also equity that we very much focused on. Equity, probably more difficult in North America's health system, and I think this is where we have a very, very big play to lead. Of course, talking to politicians, you're obviously doing fantastic. So having politicians speaking on behalf of precision or personalized medicine, extremely important, and we all know this, and driving innovation, collaborating. So nothing unexpected really in this report, apart from one thing. They call it precision health, and the reason is to include precision prevention, to include global health, public health, etc. And I think that's right, but I'll still stick with my name, because I think we can include everything under this umbrella, and I'm sure you too. So now, just the example, the Living Laboratory for Precision Medicine. So this is a large grant awarded just before COVID, and therefore slowed progress. It is about adoption, innovation, and our environment, as shown here. 38 million from Strengths in Places Fund, and huge partner contributions. So it's nearly 90 million. A lot of money has to be spent well for the benefit of patients and communities. And the ideas are obvious. We want to accelerate productivity, which is not great at the moment, support NHS, and the main economic gain, we believe, is the healthcare cost avoidance. This is what our analyses have shown. But for me as a clinician, the most important is improving patient health, improving communities' health, and that's hugely needed where I work currently. Now, we have 5 use cases. I quickly show you 4. I think they're interesting. They're in various stages of development. And I think they show the sort of spectrum of this big activity that is either being done or being planned or halfway through at the moment. So first of all, pharmacogenomics. I think hugely important because this is where we can really improve both health system and individual patient's journey. We want to reduce the burden of adverse reactions, of course, and as you know, there are really cheap and simple tests for many, many medications that are known to cause adverse reactions or do not work at the standard dose in certain large groups of patients. So that's improves both individual and the system. We used here innovative partnership procurement. I don't know if you have the same problems, but we frequently have a great innovation that comes to be ready to be adopted, and all of a sudden colleagues remember that they haven't procured anything, and there is big industrial issue there. So early procurement and open procurement, working with our top experts on procurement in Scottish Government. Now, why is this important? We use polypharmacy, particularly in people above 65, and in general medical ward, when I still used to do acute receiving some years back, that's the majority of population. And majority of them are on huge number of tablets, sometimes frightening number of tablets. I'll show you some analysis in a minute. And they get adverse drug reactions daily. We see it all the time, and you see some numbers here. So 11% of unplanned hospital admissions is due to harm of medicines, iatrogenic harm. Yeah. Now, there is big correlation, interestingly for us, between polypharmacy and deprivation. This is something about going to your GP and getting yet another drug and yet another drug, and the problem is maybe elsewhere. Maybe the problem is social or otherwise. And this multimorbidity presents a decade or more earlier in these deprived communities, like the community in which our center operates. Now, European numbers are equally staggering. This isn't a UK or Scottish problem, of course. 8.6 million admissions every year due to adverse drug events. Think about it, that's an enormous number. These are Scottish data here. Patients 65 years or more, 50% of this is preventable, and most of them are on 5 or more medicines, and you see even more in our own analysis, in our own health board. So these are the data we produced in preparation for getting the grant. This was a 2-stage, and we did in silico analysis in one health board, Greater Glasgow and Clyde Health Board, the biggest health board in Scotland. We looked at all 65 plus people, and at that time there were 165,000 of them in our Safe Haven database. And we looked at them, and you see there that average number of drugs were even greater than nationally, 8 per head. Imagine this, 8 tablets per head. The most prevalent condition, to my joy, was high blood pressure. That's my specialty. And the most costly, of course, diabetes, not surprisingly. But what's most important is that 36,000 people, these adverse reactions could have been prevented by simple test, genes spotted on the chip, simple PCR, nothing hugely complex, no need for whole genome, really cheap, and we're not doing it. Why is the question. We also looked with our health economists that we're spending enormous amount of money on this, on the care post these adverse reactions, and we could save enormous amount of money, and this is, of course, very preliminary analysis. This isn't a prospective controlled study. 85 million in 3 years in one health board. Extrapolate to whole Scotland, extrapolate to whole UK, extrapolate to whole Ireland. Wouldn't it be great to do it? Our second use case will be shorter. The idea was by small, medium enterprise working with us to do 30,000 transcriptomes based on tissue repository we have on site in our innovation hub. So the way we collect tissue is on opt-out basis. I don't know how you do it here. So every procedure, every biopsy, every surgery, every blood sample, anything that could be used for research is retained if possible, unless the patient says no. And in the west of Scotland, patients almost never say no. patients really want to help researchers, and that's been my experience for 40 years nearly. Gosh, I'm old. So we have huge data repository that is very well collected and very well looked after. So they were able quickly, I think this is almost done, 30,000 transcriptomes that are now available to industry or researchers to investigate, for example, new pathways, because there are health data attached to each sample. So it's not just the tissue, there is enough clinical data anonymously attached to the sample to give information and to be able to be hypothesis-led study. And then imaging, I waxed lyrically about imaging. It's a great tool for clinicians, of course, and shouldn't be forgotten ever. So we have raised funding separately for 7 Tesla MRI, and that allowed us to attract German company, small, very small startup, to move in with us because we were an ideal place. So that's inward investment that government's very, very keen on, politicians really like. So together with this 7 Tesla MRI, we had Siemens working with us, and this small company that is unique in making coils. This is head coils that improve what you see on 7 Tesla MRI in the brain, to the extent that Siemens is the best client, the biggest client for this company. So that's the ecosystem. That's creating something that industry cannot resist. And these are some of the pictures. And those of you interested in neuroanatomy and neurology will see, for example, posterior fossa on the top image. It's incredible. We have never seen in 3T or even 7T without these coils that level of detail. And the same with small vessels. There were vessels we've never seen before. Of course, the technology is moving. I know there is now bigger Teslas and more. But our unique strength was that this was, again, on the clinical side, next to stroke unit and main neurology for the west of Scotland. And there were other 7 Teslas across the country, but mostly in ivory towers on research sites. So my last example is digital health and validation laboratory, DHVL, as my colleagues call it. When the small startup comes into clinical questions, they are confronted with ethics, complexity. You cannot do this, you cannot access data, many blockers, and they need help. And bringing them to clinical environment with this short white code distance really, really helps. So they are provided with this secure access to both experts, data, clinical trials, how to do it, etc. And that speeds up clinical adoption. And that is really big thing, because data people don't like to work in health is my observation. It's so much easier to go to fintech, where there are also rules, but not that difficult to navigate. So what we try to do in this digital health validation hub is to go from early stage engagement with frequently very small company with very brainy young people who understand AI, machine learning, and we take them to this place of clinical adoption, and that's the holy grail. And if we manage 2 or 3, I would be hugely happy. So these are some stakeholder comments a couple of years ago, and I'm not going to read all this to you, but I will focus on one, the potential to become the Silicon Valley of precision medicine. We really like that. And the author of this, and he allowed me to quote him, is Professor Victor Zhao, the NAM, the National Academy of Medicine director in Washington, who has been on our advisory board for many years now. Now, I mentioned some COVID can't go away without this, Bernie mentioned it too. These are the lighthouse laboratories across the UK. I don't know if you heard about them. At the height of the pandemic, we had 10 of them. They listed here. We've done enormous number of molecular tests in a factory-like environment, completely automated, more machines than people in many of these laboratories. We, on the top of Omicron, as shown here in January 2002, there was a day we shall never forget, 7th of January, when we did 557,000 and a bit tests in one day as a team across the UK. You can argue, was it necessary or not? The history will argue. The reports are being published, but it was an enormous undertaking for colleagues in all these laboratories and for my central team. And I think we need a legacy of this. We can't let it go because we trained people. We did something incredible, and it would be really good to maintain some of these good things for the future. And I think it would help precision medicine. The biggest of these laboratories was the Rosalind Franklin Laboratory, which was built in the very middle of England in Royal Leamington Spa. Enormous laboratory, really like a factory. And this is, you see it on the top picture there. It was built in a modular fashion, and the builders were building, and we already had completely sterile laboratory or two functioning on the building site. I've never seen anything like that. I was responsible for it as an SRO. We wore it every day, but it worked incredibly. So what is the legacy and how could we keep it? I think we need centers of excellence, this connectivity around the world in pandemic preparedness. But I don't think pandemic preparedness is to be put on the shelf and wait for the next event. I think we need to use it every day so it doesn't go away. And we need to use skills. And the problem I see is that we want pandemic preparedness, but we don't want to spend money, and it doesn't work that way. So colleagues are devising, my successor is working very hard, and his team, to find a way to maintain this Rosalind Franklin Laboratory in the peacetime, but also to be ready when necessary. We believe that this triple helix partnership is absolute key, and I stress this, and it was during COVID. We need to maintain it and not lose it. There is sometimes a worry about conflicts of interest and all sorts of things. You can't collaborate if you don't talk to people. If you're afraid of them, you'll never collaborate. I think public-private partnerships are a big thing. I would be interested what you do. I think that's the only way to maintain some of these facilities and look into the future. And I think we need to collaborate internationally. And I'm really, really keen to hear how we can collaborate when we're out of Europe with you and others, because without collaboration, nothing will happen. So this is my summary. We have developed high-throughput diagnostics, working in collaboration. We have learned about consumer-centric care, i.e. you take a test at home, you send it somewhere, you expect a result in 24 hours to your phone. Could we not keep doing it in peacetime, is a question. We know about preventative mass screening, that we shouldn't call screening, because if you call something screening, at least in the UK, takes 2 years to get permission. But we know about polygenic risk scores coming particularly to cardiovascular and metabolic area. We know about this very early detection, especially in cancer. We need to do it. The same with pharmacogenomics. We can personalize our treatments. It's happening in cancer, but I would like this to happen in every disease, in every area of medicine. So Bernie mentioned our journal. It's launching in a month's time, on the 1st of January. This is international journal funded by Cambridge Press. It's one of the PRISM's journal. So in areas of important development, and this is the only biomedical journal in the PRISM series. We have international board, and I think there are many people in this audience I would like to get in touch with us and join us and think about working with us into the future. This is going to be an ambitious international journal bringing precision medicine to everywhere in the world. Thank you so much for your attention, and I hope there will be some questions.